Well, continue on our ongoing quest to learn about rotator cuff. Okay. So what do you think here?
I think the myotendinous junction is retracted. There's an anchor for the cuff, but I guess it's been torn, and it's retracted.
Okay, so this is on 11/22/11. So we have a partial tear next to the next cut showed that part of the construct was still intact, but we have a partial tear. I thought I had follow-up, but I guess I don't have follow-up. Okay, that's fine. And then now looking at surgical things, if you have massive rotator cuff tears, there are a number of different surgical techniques that we just a little bit alluded to on the previous one. One are the patch grafts, where you put in some fibrous tissue between the humeral head and the acromion to try to decrease pain. You can do superior capsular reconstruction, you can do muscle tendon transfers, and you can also put in a subacromial spacer, which is a little bit different than the patch graft, but there are a lot of different surgical procedures which are just designed to kind of ameliorate the pain associated with the disease. You can classify these. This is one system. I don't understand. Forget this. This is just a classification system for tears, not necessarily massive tears. I don't know why I put it this way. So the different grades. I usually describe this. I don't really like to use these types. Again, people get very confused with the different types since there's so many grading systems that I prefer to state what it is. So this is kind of a patch graft. If you have a large tear and you can't bring it over and tie it down because of chronic changes that we talked about before, we have fibrosis of the muscle and so forth, or you have too much loss of the tendon itself, then you can put in a graft here to kind of act as a spacer between the acromion and humeral head. This is kind of a more extensive area where you can do a superior capsular reconstruction. Again, that's with a large graft that goes over in this particular area, as we can see here. Yes.
Even athletes can go with a completely torn, like supraspinatus. How does this? When does this help? Why does this help?
Maybe John can address that. I see very few of these, so the indications for doing these, I think these are more at this point more experimental than proven surgery. John, what do you think?
Not seen one and not done one, and it's not in Campbell's. I'm afraid there are a lot of different things have been tried. Fasciolata has been tried. It's just like the knee. All kinds of materials have been tried, allografts and so on, and tendon transfers. The tendon transfers are extremely complex and very difficult to do with probably minimal results. Like I said, I've never attempted to do one. But a reverse total shoulder replacement has become pretty much the thing to do when the shoulder is and the rotator cuff is gone.
Yeah.
So, and it works very well. I know a guy that plays golf with a shoulder replacement from gout that wasn't treated properly. You saw his hands and wrists, John, and it's a pretty sad situation the way he was treated.
Yeah.
But either that or he didn't go to the doctor properly.
The problem with these is that it doesn't really correct the underlying problem, which is the loss of the depressor function of the surrounding muscles, and therefore you kind of expect, and my experience is that you continue to get superior migration of the humeral head, continued trauma against the acromion, and these will also break down.
Well, the deltoid is the muscle that really is a shear producing structure, and so that pulls the head up.
Right.
And then when you lose the depressors, there's no way to overcome the deltoid because that's a very strong muscle.
Yeah. And then there's
some people will. I know in Italy, some surgeons have detached the deltoid and then pulled it up a centimeter and cut down the shear force.
Okay. And here you can also, they have subacromial spacers that you can put in, but I think all these are relatively experimental. And then there's some for irreparable grafts. There are a number of other grafts that can, and tendon transfers, as John was talking.
None of these are standard. None of these are standard. Yeah. Whatever standard is.
Yeah. Shiv, what do you think of this case?
40-year-old female post-op for cuff repair and biceps tendinitis, 3 months of increasing pain. So it looks like anteriorly I see the subscapularis tendon, which looks intact, but anterior to that it looks like, is there a muscular retraction, or am I just sort of making that?
Muscular retraction.
The anterior to the subscap?
Up here?
Yeah, there's something there.
Okay, so what is that? What muscle is that?
So that would probably be the deltoid?
It's anterior deltoid. So that's acute denervation of the anterior deltoid due to damage of the nerve supply.
Yeah.
So the complication that you can see with surgery.
Yeah, that's a iatrogenic situation, I think.
Yeah. So, Har, what do you think of this one?
Abdominal views of the shoulder pain and weakness after 4 prior surgeries. So I don't see the supraspinatus, and it seems that there is like a graft material extending from the acromion to the humeral head. So I think they're like a graft.
Okay, so this is a complication that was more common in the open days. This is really a dehiscence of the deltoid, which can be very difficult to treat. They tried to treat this with graft placement here, but you can see the deltoid muscle is markedly displaced here away from its insertion on the acromion process, and this is deltoid dehiscence. Now, since we don't see open surgery on the shoulder very much anymore, except for replacements, I haven't seen deltoid dehiscence very often. John, do you want to comment on this?
Well, the deltoid won't hold. You have to, if you're going to remove an anterior portion of the deltoid to get a better view of the shoulder, this is not arthroscopic. This is an open procedure. Then you really have to stick to the bone to be able to sew it back in place. Somebody that just detaches the deltoid, there's no way to suture it back because it won't hold.
Yeah.
Suturing muscle is like trying to suture mush.
Right.
Try that sometime. Suture your
Jello?
Your Jello or your cereal.
Yeah. Okay, Thomas, what do you think of this case?
84-year-old female with chronic pain, rule out cuff tear. So there is a full thickness tear of the supraspinatus with some, I guess, granulation tissue in that region.
Yep.
Some spurring of the, and then on axial view.
So what about the deltoid?
Yeah, the deltoid's displaced inferiorly.
Yeah, there's a huge tear of the deltoid here. And I just want to point out that if you don't look for it, it's easy to miss deltoid tears. If you're just going in looking at the rotator cuff tendons, but this is the deltoid tear here is probably a more serious injury for the shoulder than the supraspinatus tendon tear. So I just want to point out that you kind of have to make a point to look for it, or you can miss it. So again, we don't see a deltoid out here at all. This is a large deltoid tear as well as a supraspinatus tendon tear. Yeah, so as you know, right now we're talking about surgical complications.
So there's a humeral head anchor for rotator cuff repair. I'd say that that's failed, and there's widening of the tunnel.
The anchor is still there, right? And the muscle, the tendon is still. Well, you said it failed.
Well, I'm not sure that. I mean, I guess that's a graft that's still intact. It looks like it was retracted, even if it's.
Yeah, the musculoskeletal junction is retracted back a little bit. So this is probably a little bit of a tear with retraction and scar In-Situ.
Right.
But this it's a single suture anchor here that's very proximal. So it may very well be that they anchored the supraspinatus tendon more medial than would be normal. But what's the main thing here is the tunnel, right?
Yeah, it's widening.
And we have a lot of edema surrounding the tunnel, and the tunnel widening. Yeah. And there's a lot of fluid around the suture anchor. So this suture anchor is not going to be in there for very long. So what is this?
Looks like some kind of inflammatory reaction to the metal. I mean, the metal still looks intact, but
it's not metal. You don't really see metal artifacts.
Oh, that's true.
So this is a resorbable suture, and as we talked about, some of the older resorbable sutures can produce inflammatory reactions. We saw a few of these, I think, in the knee, and this is just an example in the shoulder. The current resorbable anchors that are used now, I haven't seen this very commonly on at all. So I think they no longer use these kind of anchors, so this complication is much less common now than it used to be. But what you often have to do is take this out, repack it with bone, let that mature, and then go in and do another reconstruction if the defect is too large. And here's another suture anchor cyst, also the same thing. This one not quite as bad as the previous one.
Okay, so 2 coronal images of the shoulder, and it looks like there is a rotator cuff repair of the supraspinatus, and it looks like the suture anchor has dislodged and is proximally
So there's probably 2 rows here, and the proximal suture anchor is dislodged, and so that's a displaced anchor. And there's probably some white.
This looks like a double row technique.
Right. Yeah. With this one, you can see that there's widening of the tunnel here, and in this case, it's enough to where the actual suture anchor dislodged. And we can see that the graft is torn and retracted back into here.
They did a pretty good trench there.
Yeah.
And it's obvious that the muscle was quite tense, and if you notice, they had to go into that part of the head to get enough purchase to the tendon. So they had to really pull on it to get it into position.
Okay.
For suturing.
Yep.
So this would be very tense, and it's not not a surprise that it tore.
Yep, good. Okay, Sahar, what do you think of this one?
Okay, two corneal views. We have a low-grade partial thickness or surface tear of the supraspinatus, and there are some areas of low intensity in the inferior joint space. So I'm wondering if those are like loose bodies.
Look like what?
Loose bodies.
Yeah, here, yes. That's a patient had an anchor that pulled out and displaced inferiorly. Okay. Thomas, what do you think of this case?
63-year-old male with shoulder pain after surgery. So, yeah, it looks like they have a suture anchor that's dislodged and displaced kind of inferior to the AC joint and retracted.
Right. And it probably came out of here, which again is a little bit proximal. Okay. Let's see, and then here are the axial images where we can see back here.
One thing about the anchors, they're not always easy to find. In fact, they're hard to find. I know some patients that I was asked to consult on, and the surgeon went back to remove the anchor and reconstruct the shoulder and couldn't find the anchor. I don't know too many cases, but when they get loose, they can be a real problem.
Okay, great.
Because they can lodge any place in the shoulder.
Yeah. Okay, Sam, what do you think of this one?
There's some hypo-intense material over the humeral head there. I would think it's calcification. I don't know what kind of operative complication. Yeah, so it looks like calcification.
So what is this?
Could be calcific tendinitis, subspinatus.
So calcific tendinitis is really a deposition of typically hydroxyapatite or calcium pyrophosphate in the soft tissues. A term for when you have symptoms associated with it is pseudogout, as you're all familiar with. You have to have CPPD deposition as well as clinical symptoms. It's often, you can often see chondrocalcinosis, which is a different calcium deposition in articular cartilage. Really, and then you can also have hydroxyapatite deposited. The bottom line is that the bottom line with all of these is they typically occur where you have chronic degenerative disease or tearing and disruptions of the fibers of the collagen. And I think is what that does is expose chemical, it unravels the triple helix and allows areas where calcium in the interstitial space to absorb onto the abnormal loose ends of the collagen, which gets exposed. And in the right milieu, and the people who have the right biochemistry, that can start the development of a crystal in that area, and eventually it can get large enough where we can see it on MR. It's always been thought in the past that calcium deposition produced an inflammatory reaction, or the body reacted to it in an inflammatory way, which then can lead to pain and symptoms. And that certainly may be true. We also know that these will typically resorb over time as well, and sometimes they can come and go relatively rapidly. The time course, they can stay forever, or you can see them and 2 months later they can be completely gone. Typically, the symptoms will resolve mostly when it's gone. I really think that this is a biochemical response to partial tearing of tendons and ligaments, primarily, not a primary disease process of deposition of the calcium into the soft tissues. I think the calcium deposition is secondary. Not everybody agrees with that. And I think a lot of the pain associated with this are actually partial tears of the tendon, interstitial tears of the tendon, which may be the actual cause of the calcium deposition rather than the other way around. But that's still very much a debated issue. But it tends to be very much associated with aging and degenerative type tendons that we do know, which would fit in with that. And there's a lot of thought about the different biochemistry that can be involved to allow calcium deposition. And so I think this is the most common. It's interesting that you can, if you have mature calcification without any edema around the tendon, those individuals can often be asymptomatic, and we can see that on MR, and then in a lot of areas of the body where this happens, that chronic calcification can go on to an ossicle, and we've seen that, and a lot of those are thought to be congenital, but in reality, we now know, as I've said before, that most of those are acquired, and we've got many of examples now of MR where you had a normal tendon, you have a partial tear, and then years later you've got an ossification right in the area of the partial tear. And there are certain locations where we know tendons are under the greatest strain, and some ligaments as well, and then that tends to be where these ossicles occur. We'll see a lot of them in the foot and ankle, and we'll see some in the elbow and talk about them. Some people believe that during the resorption phase these can be painful. I'm not sure that has to do with resorption. I think it has more to do with an injury, surrounding injury to the tendon itself. And
if I was to guess, most of the calcium that we see on X-ray or MR is asymptomatic.
Yeah.
And then trauma probably sets it off. But I don't know. That's just a guess on my part.
Yeah. That's what I think too. You can aspirate these, and actually is what you ends up with is more a milk of calcium rather than a hard single crystal. These are small microcrystals that are often in fluid, as we can see here, which is a typical appearance.
Do you believe this is therapeutic?
Some people believe this is therapeutic. The lidocaine put in is probably therapeutic. My guess is that the removal of the crystals really has no impact upon symptoms or the course of the disease. John?
The consistency is from fluid to solid, like an ossicle. They're all different kind of consistencies, and each of them will produce symptoms except the solid ones.
Yeah, and I've seen quite a few of these. It turns out that I've seen a number of calcific tendinitis in the shoulders of wives of radiologists in this group, including one of our interventional radiologists who wanted to aspirate them, and the wives refused, and they got better within a month or two, being just left alone. So you can certainly aspirate them, but I don't know any really good data to prove that that's helpful. John?
I've done a lot of them without any fluoro, and I think one aspiration usually works. Okay. With cortisone. I have had to inject 2, probably maximum 3 times. I wouldn't do more than 3, and the symptoms went away. And I would go to these from the posterior aspect, or depending on where it is, of course.
Yeah, and here's the European League Against Rheumatism classification for CPPD. And here their thought is that this is really produces an inflammatory reaction, as you can see here. The inflammatory arthritis associated with CPPD, most people I know now believe that it's degenerative disease, and you get secondary CPD, calcium pyrophosphate crystals deposited in the surrounding degenerative tissue, not that the CPP crystals actually induce in the inflammatory reaction, but there's still a lot of disagreement on that particular point. Generally, these are very degenerative type discs. They do not really respond to typical anti-inflammatories. They don't respond to the same medications that you use for rheumatoid arthritis. which suggests that it's not really inflammatory, and you treat them symptomatically just like you do degenerative disease. So I think the presence of the calcium was important in the past when we only had x-rays to evaluate the joints. That's what we saw, so we attributed a significance to it that was probably beyond what it really is appropriate. All right, let's see, who did the last one? I think Thomas, what do you think of this one?
So yeah, there's multiple foci of looks like calcific tendinitis at the bursal surface of the supraspinatus.
Yeah,
a little bit of thickening.
So we have the focal areas of signal loss on all sequences, which is probably calcification. This looks to me like it's more within the bursa rather than within the tendon. I think you could call this, this was called calcific tendinitis by Philip. Since it's not in the tendon, I think a lot of people would call this calcific bursitis. Some people would call this, what is it when you have multiple calcific bodies in the joint? Yeah, a lot of people call this osteochondromatosis. They would divide that into two types. One where all of the calcified bodies, and sometimes non-calcified bodies, or the same size, look like grains of rice, which I think is a true disease. And the other where you have irregular calcified bodies like this of all different sizes and shapes. And I think this is really more degenerative ossicles within the joint rather than a primary metaplasia of the synovium.
One thing I remember that's kind of interesting. Once you cure these, they don't come back, which is kind of interesting. Or at least I've never seen a case of mine that came back.
Okay.
I don't know about your experience.
I don't remember one that went away and came back.
Once you cure what? The bursal?
What?
Sorry, once you cure what, does it come back?
Any of these calcific deposits in the tissues that are symptomatic.
Oh, okay. Because I thought Dr. Reguda said earlier that he did this calcium aspiration a few times for patients in the past.
John, did you hear the question?
Sorry.
I know I didn't.
I'm sorry. Didn't you say earlier that you've done aspiration of calcium from tendons in the past, and that you did it for multiple procedures, like up to 3 procedures?
I don't think in the same.
No more than 3.
Oh, you haven't. Oh, you haven't done more than 3 total, or more than 3 patients?
Oh no! I'm talking. No, you only do 3 injections maximum. You don't fool around anymore. You go and get them surgically if that's necessary. No, I've done probably a couple hundred of them.
Okay.
If not 1,000.
Okay. Sam, I think it's
57-year-old with intermittent shoulder pain for several.
I'd like to ask one. I'd like to ask a fellow, how much contact does the humeral head have with the glenoid?
You mean what percentage of the humeral head? I guess depends on the position. I don't know. 0? The trick question.
How much contact does the humeral head have with the glenoid surface? Yeah, percentage.
Yeah, I don't know.
small little T.
Okay, I won't waste any more time. 25%.
So it's basically a very.
And then if you add the labrum, that increases to 50%. And the depth of the glenoid with the labrum gives you. I'm sorry, that it increases to 75%, and the depth of the labrum it gives the contact 50%. So anyway, sorry to interrupt.
Thanks, John.
Thank you.
but the contact is really very small,
Okay.
and the amount of force that's involved in the shoulders is quite massive when you figure the amount of activity.
Yeah, you ought to bring that back up again when we get to rotator cuff tears and instability.
Okay, John.
Good.
I'm sorry to interrupt.
Thank you. So this is pain years after an injury. Then the patient had 48 hours of acute intense pain after yoga. And again, there's a calcium deposition. And here I think there's a lot of edema in the tendon. So maybe true tendinitis here in this case. Yeah, more of the same. There's edema. There's the calcification. Yeah, calcification and edema. So calcific tendinitis.
Okay, so some people recommended that this get aspirated, and she refused this, and she was treated by nonsteroidals and physical therapy and no interventional procedure. And let me just see here. And her symptoms completely went away after 6 weeks.
But that was so unnecessary. It could have been cured within 24 hours.
Okay. So the issue here has to do with the mechanism. Did the trauma, did this produce increased trauma in the surrounding tissues, which with yoga, which caused the pain? Did she strain something with yoga? Or is there actually an inflammatory reaction from the calcium itself? And it's hard to say here. Certainly we see a lot of edema going into the muscle, which raises the question whether it could be a muscle tear, or if you have inflammation, it could be inflammatory disease of the muscle. And then this is what it looked like 14 months later.
Oh, the calcification.
That's a dancer we know, isn't it, John?
Yes, it is.
Looks like it's healed, sure enough. Yep.
Okay, so this was kind of an example of symptomatic calcific tendinitis, and yeah, it was recommended that for her to have it aspirated and have steroids and lidocaine put in, but she refused.
What was the time point on the previous?
Okay, here is 4509. Her symptoms persisted for 6 weeks, and then we're talking about 14 months later. Okay, all right.
Okay, so it looks like we have a radiograph and 2 MR images, and it looks like there's calcific tendinitis and the expected position of the supraspinatus on the radiograph. And on the MR, it looks like similarly the expected position of the...
Okay, what about the bone?
The bone looks like there's an erosive change.
Fat set.
Yeah, it looks like there's sort of this punched out focus of...
So what's going on here?
I'm not sure about that.
We're not sure about what, John?
Erosion.
Okay. Well, I guess to me it looks like an erosion, erosive calcific tendinitis.
So this is something that's actually called erosive calcific tendinitis, and that you can actually...
Well, I was wrong.
You can actually...
It won't be the first time.
Yeah, I'm wrong.
That's I don't know. It just looks like the bone is got more calcium than the rest of the head, but I don't know.
Okay, so this is erosive calcific tendinitis, which is a kind that tends to be more symptomatic. And the question is the calcium here in the soft tissues producing an inflammatory response that then erodes bone, or is this primary a traction injury, and these are all healing responses? Again, I don't think we really know the answer to that.
So that calcification is CPP.
Are we trying to say that this is a separate kind of a disease?
No, it's the same disease, but
Yeah.
but it has a different name because you can get bone erosions associated with it, and therefore it's called erosive calcific tendinitis. I believe it's the same disease. It's just a little bit more severe, typically more symptoms because it's also involving bone.
Okay.
And we see a lot of edema within the bone, suggesting an inflammatory response.
Yeah, I see that.
So, Harm, what do you think of this case?
Okay, so we have calcific tendinitis at the insertion of the first minus, and there's some erosion also at the attachment. So this is another example of erosive calcific tendinitis.
Of this process, and so we could argue all day long about kind of what the mechanism is. These are all basically treated similarly, and okay. Let's see, Thomas, what do you think of this case?
70-year-old female with severe shoulder pain. So yeah, there's foci of low signal intensity at the supraspinatus, consistent with calcific tendinitis. I guess some thickening of the subacromial subdeltoid bursa, and some edema fluid.
Okay.
Subacromial subdeltoid bursa.
So what are you going to call this?
Calcific tendinitis of the supraspinatus. There's some atrophy of the...
A lot of edema within the muscles here, right? But both of the deltoid was involved, the supraspinatus is involved, the infraspinatus is involved with these foci of low signal. You go to a CT scan, this is what it looks like on the CT scan. So,
there's calcifications along the...
So this is a more example of calcific tendinitis or CPPD disease, much more extensive. And again, how much of this is inflammation, how much is muscle tear is something that...
I wonder if there's some kind of endocrine disorder.
I don't know. Sam?
45-year-old with shoulder pain, no trauma. I guess I have an attending that would call this calcific periarthritis. So I guess that's what I'll call it.
Yeah, except...
Non-specific.
Whatever that means.
Yeah, exactly.
I think it's...
Okay, well, an MR helps.
Period. Articulate what it means, but this is what the MR scan looked like.
Okay, so I guess the calcification doesn't look as impressive here, but there is some increased signal in the tendon, a little bit. There's also increased,
Look at all the bone stuff.
Yeah, there's also increased signal in the bone.
That's in contrast.
T1 fat sat post. Is that fat sat pre on the left?
It's a fat sat pre on the left.
It is. Okay, so, this is enhancing around, I guess, like a chunk of bone or something. Pre and post. Well, it looks like a lot of enhancement in the marrow here. I guess inflammatory. Yeah, okay.
This is an enchondroma.
Oh, an enchondroma.
And you also have an erosive tendinitis. And I would call it tendinitis. This is the tendon insertion. And this calcium is almost always in the tendon, either that or it's in the bursa. Yeah. In this case, it's actually going into the bone, which we can see with the MR scan. So I would prefer to call it, I think this is in the tendon, so I would prefer to call it tendinitis, and then we're just, so anyway. And this just happened to have an enchondroma next to it, which is,
so that thing with
this is all in, this is enchondroma here.
Yeah. That last picture, one behind here, if you don't mind. Not that, sorry, the next one. So that on the right, so that's the bone we were seeing on the x-ray inside the humeral head?
Yeah, well, so what you're finding here is that you have either trabecular bone injury or inflammatory disease, which is enhancing here.
Okay.
anterior shoulder pain MR arthrogram. So, looks like there's a hypointense structure sort of the expected position of the anterior labrum, adjacent to the, yeah, just anterior to that.
Are you talking about this?
Yeah, is that the MGHL?
Yeah, I think it's Milgren ligament.
Okay.
So what's this?
Yeah, then there, it's sort of near the insertion of the subscapularis on the lesser tuberosity.
There are more images.
And it looks like the lesser tuberosity itself, excuse me, the subscapularis tendon, there's a little bit of high signal in it there. Thinking about tendinosis and a low grade or partial.
It's pretty sharply defined there. Yeah, this is actually the needle track.
Oh, it's the needle
See,
track.
there's a little bit of contrast in the muscle there. This is all from the injection.
Okay.
And I've seen this called disease within the subscapularis. Just remember that when you stick the needle through it, though, you usually get contrast leaking along the needle track, and sometimes it can be misinterpreted as subscapularis tendinopathy when it's not. Okay. Sahar, what do you think of this case?
So, anterior shoulder pain, there is high signal in the subscapularis. Let's say some tendinosis with the low grade Reconstruction here, and there is also
Thomas, what do you think of this case?
Anterior shoulder pain, so it looks like an axial view at the subscapularis tendon. There's some tendinosis.
Yeah. So this is a little interstitial partial tear. I think it's perfectly fine to call this tendinosis here. And it may or may not cause symptoms, but it's not going to be seen looking at either surface of the tendon. So I think it's reasonable to call this tendinosis. Good.
Hmm.
This is T1 and T2. Okay. All right.
Okay. So the sagittal looks like there's some little bit of irregular. Well, I guess the sagittal shows interstitial tear of the subscap, partial tear, and then it looks like delamination on the axial.
Yeah. So this is an interstitial partial tear, right? So we're getting different degrees of injury to the subscapularis tendon.
And similarly, it looks like a high-grade partial tear of the articular surface of the subscap.
Yeah. And then what about the bone here?
And it looks like there's a little traction injury there.
Yeah, I think it's a traction injury. So just like we saw with the supraspinatus, where you can have a postal lesion, you can get injuries of the subscap where the deep fibers will basically avulse a little bit of bone, producing an erosion here, and you'll get a tear of the joint side surfaces, and the superficial surfaces can stay intact. So it's kind of like a postal lesion. I don't see the retraction as prominently in the subscap as in the supraspinatus, but this is probably due to chronic traction injury of the subscapularis. We don't see bone injuries quite as often in the subscapularis as the
posterior, you see irregularity of the head also. Yeah. So on our way to arthritis.
Okay. Sahar, what do you think of this case?
so there is severe tendinosis and moderate partial tear of the subscapularis soft fibers, and there's a lot of fluid around that.
So here's the like relatively well here. It looks like we've got a lot of thickening. What is this structure here?
Is this the biceps pulley?
Now this is the transverse ligament. The superficial fibers of the subscap cross over the intertuberous groove and attach to the greater tuberosity, and they help stabilize the biceps tendon and the groove. We'll talk more about that when we talk about biceps disease later. but this is a tear of the transverse ligament across here, and then we can also see a lot of fluid in the subacromial subdeltoid bursa. Thomas, what do you think of this case?
So you have two axial views, some cystic change of the posterolateral aspects of the humeral head, and the subscapularis, if there's some interstitial tearing within the tendon.
Right. And then we can see a subchondral cyst here, which is due to chronic traction injury of the subscap. And there's also a little bit of flattening of the biceps tendon and a suggestion that it may be perched a little bit. And again, we'll talk about the pathology. The common pathology here used to be called the hidden lesion, which has to do with instability of the biceps and these interstitial tears and the subscapularis when we get to the biceps tendon. It's a different lecture. Okay.
The subscapularis looks, I guess, torn, full thickness tear here. I guess it's retracted. I'd call that a full thickness tear.
Yeah. So that's a field scanner. It's a subscapularis tear. This is an acute tear. As you can see the sharp margins.
13-year-old male, status post-football injury. And let's see, looks like there's quite a bit of edema within the lesser tuberosity, and it looks like the subscap is not necessarily
back over here. It's hard to see here. There's some edema here, and better seen on the axial images.
Yeah, so it looks like a full thickness tear of the subscap there.
Yeah. This is a lesser tuberosity. This is actually a little fluid here and a little displacement of the bone. This is a minimally displaced lesser tuberosity avulsion fracture. So you want to stabilize these and let the bone heal, as we've talked about in other areas. Sahar?
We have three high-grade tear of the subscapularis with some proximal retraction. I don't see the bicep is kind of a little version.
What do you see on the sagittal image?
There is an avulsion fracture in the attachment of subscapularis.
So here what we see is some abnormal signal intensity within the subscapularis tendon. If we go to the sagittal, it looks like we may have a little ossification in that area. And if we go to the plain films, we can see a little ossicle sitting right there in this patient. And this is a chronic injury where an ossicle is developed within the tendon.
So it's not an avulsion, it's just...
It's probably not an avulsion. It's probably an in-situ development of an ossicle, just like the ulnar collateral ligament that we'll talk about, just like the os perineum and the peroneus longus tendon of the ankle. If you have chronic injuries, you can get ossification in those areas of chronic injury. Okay, Thomas, what do you think of this one?
50-year-old female, pain 3 years post-op. So there's susceptibility artifacts at the lesser tuberosity, so maybe from prior subscap repair.
Okay, good.
And so there's an axial view, and I'm not seeing some atrophy of the subscapularis and attenuation of the tendon.
So there's atrophy here. The musculotendinous junction is markedly retracted. So what do you think?
So yeah, that would be consistent with a re-tear of the repair.
Oh yeah, so this is really a failure of the construct, and this is retraction, and this is scar in situ. It really looks like that the construct may be intact all the way to the suture anchor, but what happened is that it was torn to about here, and this was all just scar tissue. In this particular area, whatever it was non-functional at this point because it's displaced too far medially.
That's a funny place for the anchor.
Yeah. Okay, right, Dan. Okay, let's go on and talk a little bit about the biceps, or we can start that. We'll finish it tomorrow. So there are several different classifications for instability of the biceps, and they're all kind of similar. The one that I kind of like is the Bennett, but we'll talk about some others in a minute, which a lot of surgeons, and I've modified this one a little bit. So when we talk about instability, there are different grades. And again, I don't like to use the grade because, as we'll see in a minute, there are different grading systems for the biceps, and it's different depending on how you grade it. But in thinking about biceps injuries, I think of the lowest grade 0 would be an injury of the sling that we're going to talk about without displacement of the biceps. Grade 1 is when you have a perched biceps, which we'll talk about, but it's not dislocated, at least not on the imaging at that time and in that position. Grade 2 is where you have a displacement of the biceps tendon into the subscapularis tendon. Grade 3 is the biceps displaced into the joint space. Grade 4 is a displaced tendon anterior to the subscapularis. Number 5 is a dislocation of the biceps with subscapularis rupture. And number 6 is a posterior dislocation of the biceps, which is exceedingly rare. And the last, grade 7, is a complete tear of the biceps. These last 3 really aren't published in any published papers. So if we look at this, here we can see, here's the subscapularis tendon. The deep fibers are actually torn here. The biceps tendon is flattened and elongated with some increased signal intensity, and it's perched over the lesser tuberosity here. It's not completely displaced out of the endotuberous groove, but it's perched in this situation. So, and then we have a partial tear of the subscap. I don't know why this is here. Anyway, here we can see a tear of the subscap and some edema. I don't know why I have that in this location. Forget that. I'm sorry, I don't understand why I put this in this section. Oh, well, that's just a torn subscap. Here's just an avulsion of the bone with a subscap injury. I think these are on the wrong section. And here we can see a little bit of the bone that's avulsed off. And this kid, a typical kind of injury you would see in a younger child or 10 to 13, typical age group for this. Okay.
Their tendons are strong.
Just a second. I'm trying to figure out why I put this here. I see. I'm sorry. This isn't the section where I'm talking about the biceps tendon. Sorry. These are the 7 things that Dick Hawkins wanted in a report when it came to rotator cuff tears, and one of the things was the status of the biceps. So I'm just showing here. So this is the grading system. We're going to talk about this in much more detail in future lectures, where I have lectures just dedicated to this. But these are the things that we'll look for, and we'll talk about those in detail at another lecture. This just shows some of the injuries of the subscapularis tendon and how they can be intimately associated with the biceps. But we'll talk about the details of the biceps in further lectures. And here's just a complete tear with retraction of the subscapularis. So we're still talking about the subscapularis here, not the biceps. Sorry about that. Now I understand. And we have some muscle edema from a muscle injury in this particular case. Let's see. Oh, and then I just talked about that. This is an avulsion injury of the bone for a subscap tear. Okay, let's see. Who's next? Or who was last? Sam? Sure.
So there's a bone fragment, pretty large bone fragment. I wonder if that's glenoid. It's too big to be glenoid, I guess.
And then here we can see a big fragment of bone. Good. And this was a chronic avulsion fracture of the lesser tuberosity, which displaced back there.
Okay, 29-year-old male, rule out subscap tendon tear. So again, it looks like a pretty large avulsion fracture.
And there you can see kind of massive, another old lesser tuberosity avulsion fracture. Sahar?
Hypoglycemia line.
Avulsion from the teens.
I'm sorry.
So it's like, is it calcific tendinitis of the subscapularis?
Loss of signal intensity and the calcium. That's right. John, what did you say?
I said that the ones you showed earlier, the avulsions are old, from the teens.
Right.
The 29-year-old.
Right. Exactly. And it's been there a long time, and that ossicle has probably grown over time. Right.
Yeah.
Good, John. Okay, Thomas, what do you think of this case?
So an axial and a sagittal view in the subscapularis. Looks like there's partial tearing. Biceps tendon is still within the groove. And on the it's just like interstitial tearing of the subscapularis.
So this may be a tear, but some people believe that you can actually have a bifid subscapularis and have two tendons from it, which may not be fused. And here it looks like the margins are pretty distinct on all the images. There's no real edema in the soft tissues here, even though there's joint fluid extending in between the two here. And this was thought to be a congenital bifid subscapularis tendon. I'm not sure if that's exactly what it was, but this has been described as a congenital variant. So why don't we stop here, and tomorrow we'll finish the lecture on the rotator cuff, and then maybe I'll do the second lecture I'm giving for the International Skeletal Society meeting tomorrow as well. Okay?
Thank you.